All right, thank you so much for staying with the Monday Report Town Hall session. You're just in time for this conversation at the Sarova White Sands right here in Mombasa. It is freezing cold at the coast, by the way. It's a very strange phenomenon for all of us here. But yes, this conversation begins right now at Trevor Mbiji at Citizen TV Kenya. Use the hashtag Monday Report. Also text in 22422. We're talking about people who use and inject drugs and the new HIV transmission amongst the key populations. We are calling it closing the tap. It's a double-edged sword of some sorts, but we want to wade through it and hear from you and your views. How do we then protect the people who are using drugs from contracting HIV without increasing the stigma that is associated with drug abuse and HIV at the same time? All right, that's the conversation we're having. Let me introduce my guests really fast, beginning right now. Dr. Ruth Laimon Masha, the CEO, National AIDS Control Council. Thank you so much for making time. Dr. Kate Ngugi, head of NASCOP. Asante sana for making time. Dr. Adija Shikeli, the Chief Officer, Medical Services Department of Health in the Mombasa County Government, is also here with us. Thank you for making time. Hussein Taib from MEWA, the Community Service Provision, is also here with us. Miss Agnes Irungu is also here, Program Officer, National Police Service. Thank you for making time. And Taib Abdul Rahman, Reach Out, from Community Service Provision as well. We have an audience of about 10 people. We'll be speaking to them to find out what is the best way of dealing with this. But without any further ado, let's start off from the host counties. And Ms. Adija, Dr. Adija, I'll come to you on this. Let's talk about the numbers. What then is the correlation between substance abuse and HIV transmission in Mombasa specifically?
Thank you very much, Trevor. Karibuni Mombasa.
Asante. Kuna baridi kweli.
Kuna baridi na mvua nyingi. Hii ndio Mombasa. Okay, so we actually have 3,500 people who inject drugs in Mombasa, and out of those 34.8% have already been enrolled in the methadone program. So we're talking about 1,480 clients on methadone, and 12% of those actually have HIV, so they are positive. That's about 420 of them. What we are doing in Mombasa, we're working with, it's a multi-agency approach. So we work with, of course, the national government, NAC, NASCOP, even NACADA. We work with the CSOs and CBOs, MEWA and Reach Out that are here with us today. We work with donors, UNODC, USAID. We work with prisons, we work with police, we work with the law enforcement. And this, as I said, is a multi-agency approach. We do not work alone. This is a big problem. And the other thing is we have increased accessibility for these people with, who inject drugs and who have HIV. So we give a comprehensive treatment at our methadone programs. And we started with one. We now have 5 methadone programs or centers in Mombasa. We started with Coast General Hospital. We went to Kisauni. And then we have Portrees as well. And 2 of the centers, we have partners. We've worked with prison, Kenya Prisons Services. So there's a methadone program at the Shimolatewa prison, which is the first in Africa. In prisons. And then we have one, of course, we collaborate with NACADA and NASCOP and other agencies, with Ministry of Youth at the Miritini Center right now. We are also working very closely to reduce stigmatization and discrimination, and also social integration, family and social integration with the CSOs very closely as well.
We'll come to the details of the integration in just a bit, and stigma as well. But Dr. Kate, let me bring you in on this. So how many infections in Kenya are directly attributed to people who inject drugs, and what is the best way of dealing with this? Because even just saying it, that people who inject drugs, makes it seem like you're trying to separate them.
Thank you, Trevor. We have around, our estimate is around 35,000 people who inject drugs in the country. But we are working with a target of around 27,000. Out of the 27,000, around 18,000 of them are on needle syringe program, with around 8,000 on medically assisted therapy, that is under methadone, in around 9 counties in the country. Now, out of those, we have around 6,000, approximately 6,000 of them who are HIV positive. The prevalence of around 18%. But the ones who inject drugs and are sharing the needles, the prevalence is around 31%. But the ones who are not sharing the needles is around 4%. Now, out of the 27,000 people who inject drugs in the country, we have around half of them, no, 11% are women, and around 3,440 are under 18 years of age in the country. And you know, if you look at the 9 counties, we're talking of Kwale County, Mombasa, Kilifi, Lamu, Nairobi, Kisumu, Kiambu counties are the ones we have highest number of people who inject drugs. But still we have around, as I've said, around 13,000 people who use drugs, the smokers or sniffers in the country. But in terms of the ones who are HIV positive, around 6,000. Yes.
And Dr. Ruth, let me bring in on this. We know there's a very intrinsic relationship between drug use and sex work, especially among women who use drugs. What have you witnessed in the course of your work with this sort of group?
Thank you, Trevor. Indeed, there is a close relationship between sex work and drug use. Partly because the nature of sex work itself sometimes cause for somebody not to have inhibited kind of behaviors. So you find that sometimes the sex workers who start using drugs, it's usually as a mechanism to cope with the sex work itself. And also sometimes women who inject drugs, for example, tend to get into sex work so that they can sustain the drug use because they need to buy that drug. So then the relationship between sex work and drug use comes in there. One where somebody wants to inhibit behaviors, the other one is where the sex work itself is done as an income generating to sustain the behavior. So because of that, then we find that we have programs that interlink both people who inject drugs, but also we give comprehensive services to also sex workers, including discussing about the need for sex workers not to also get into drug use.
All right. Ms. Agnes, let me bring you into this because yours is a very interesting position. You're dealing with people who drug abuse itself is illegal, but then they also have a possibility of contracting HIV in the process. Where do you draw the line so that you don't victimize people who are already dealing with the issues in the society? They are dealing with drugs and there's also possibility of being infected with HIV, but you also have to stick to the law. Where do you draw the balance on this?
Thank you, Trevor. Actually, that's a very tricky, it's a really tricky situation for law enforcement because we really need to look at what the law says, but at the same time, we really need to strike a balance between now support for the user and actually not victimize and also actually sensitize our officers on how to deal with issues to do with rights, which are universal. So when you're looking at the user, you're not looking at this person as a person who is actually not in contravention of the law, but at the same time, looking at this person as somebody who really needs help. So there's a very, very thin line. But at the same time, we don't say that drug users are not in contravention of the law, because the use itself is actually against the laws of our land. But at the same time, we also have users who are also in petty crime. So where do you draw a line? Do you support this user just because he's a user? Or do you also look on the other side of actually the petty crime? At the same time, when they come into the stations, we're also looking at the health aspect of it. There's the withdrawal syndromes. Where do you refer them for services? So even as we are looking at what the law says, we're also looking at the human rights-based approaches. So we're also looking at, okay, this person really needs to be incarcerated. But at the same time, they also need support. So at times, it remains at the jurisdiction of the commanders to either move the case forward to the judicial system or actually refer them for medical treatment.
Let me bring in Hussein on this, and you can pass him the microphone where the microphone is. They've been already sanitized here. And we're talking about this issue of the Kenya Narcotic and Psychotropic Drug Act of 1994. Legally speaking, people say it is old. does it really respond to the new challenges in Kenya, recognizing that the SUDs is a disease condition that will need public health and human rights? Does it need to be changed? Does it respond to our current needs?
Yeah, definitely there is a need for change. And the need for change, a lot of things has been happening. So it's prudent, it's necessary for it to be changed. But the question is, what are we changing? That is what we need to discuss, and we need to see how we can actually sort this thing out.
Yeah.
There is an amendment right now, has passed the parliament, and it is waiting for the president's assent. And we have been arguing as stakeholders, the caucus, for harm reduction.
Yeah.
We've been working very closely with all these government agencies. The Ministry of Health is in the front line.
Yeah.
The Department of Health, Mombasa County, at the front line. The issue is the law has been passed. The parliament has passed the motion.
Yeah.
The bill is at the president's desk waiting to be assented.
Yeah.
We have been pleading the issue of harm reduction. We have been working here in Kenya and Mombasa and the rest of the country doing a commendable job when it comes to harm reduction.
Yeah.
It is an evidence program. We have achieved a lot. The problem, this new amendment has not considered the plight of drug users. The issue of possession is a very complicated issue. They have failed to look at the addict as a victim, and they're treating him as a villain. The issue of possession for drug use is an issue. The issue of trafficking, yes, we are okay with the trafficking, but the penalties that has been set aside for possession of minimum quantities of drugs is going to really affect the services and the achievement that we have done through the years.
Yeah.
So what we have been actually arguing and going to the extent of sending a memorandum to the parliamentary committee that was in charge of this, is there were some issues that needed to be taken into account, so that the work that we've been doing with the people who use drugs is actually considered in this. So a small portion of drugs people will be taken. They have not seen a drug user as somebody who is affected, somebody who is sick, but they have criminalized drug abuse, and this is an issue with us.
What would you suggest? What do you think would be the best way, especially when it comes to the possession part?
Thank you. Actually, to start with, they should have gone on the preliminary to try to identify, to distinguish possession for personal use and possession for trafficking. This is missing. So this is the point of contention. That is number one. They should distinguish between possession for personal use and possession for trafficking. That is number one. Number two is the penalties. They have not specified the penalties that are actually put for possession. Is just too much. Somebody is going to be taken in just for a cigarette, one cigarette of bang, to a maximum of 20 years in prison. That is a problem. Most of these people are sick people. They have got HIV, hepatitis, TB, sexual reproductive diseases, and for them to be taken into prison, it is an issue. Especially now we have young drug users. Young drug users are the prison services equipped to handle all these people? That is number one. Another thing that is of contentious is the issue of Maineo. They have actually put whoever is going to be found in a place that is actually drugs are being used. So anyone who has been fined in that place a penalty of 250,000 shillings and not fine not more than 250,000. What is contentious about this is even the landlords. If somebody is owning a house, is in Nairobi, he's got a house in Mombasa, and is drug users have been caught in this house, anything to do with drugs, the landlord is also liable for a penalty of not less than about 10 years and a fine of 20 million shillings. These are things that are just unacceptable. Additionally, the issue of rehabilitation. This is what we have failed to see. The current law Psychotropic Substance Control Act of 1994, in Part 5, has detailed the issue of rehabilitation. Has mandated the minister in charge during those days before the new constitution. The minister was actually mandated to put up rehabilitation centers in everywhere where there is a problem of addiction. That never happened. This is now a question that this panel here, these ladies here, they have to come up with answers together with other stakeholders. So from section 51 to section 58. Section 58 is talking about the judicial services. The magistrates have been mandated, once they have been able to realize, once they'll be able to accept that somebody is an addict, somebody is suffering from addiction, the magistrate have got the mandate to actually put him into rehabilitation services. So this is not happening. So what we have actually proposed, the caucus that reach out and many more have been a part of, is for those who are caught with possession, a minimum amount that we have specified in this new amendment is they should at least be referred to rehabilitation centers. Those with a minimum of 100 grams or less. Those with more than 100 grams of cannabis, and it has been proven that they are for use, they should be taken to longer terms of rehabilitation. So what we are calling for, drug users to be given treatment and rehabilitation services instead of them being incarcerated. Thank you.
All right, Abdul Kamal, I'll come to you in just a bit as we sanitize the microphone when you're passing it over. Dr. Ruth, you had mentioned the issue of women who use drugs, and now what are the special needs for them specifically?
Trevor, first of all, let's remember that in every 100 women who use drug, around 44 of them will be HIV positive. Now, with that kind of high prevalence, one of the areas you see gender inequalities is among women who use drugs. Generally because of stigma, it's difficult for them to be accepted. But also, it is one area where women's sexual and reproductive health gets very abused because of the fact that in most cases they are not seen as people capable of to protect themselves. The challenges include sexual abuse, because sometimes women who inject drugs may not recognize themselves in some circumstances and people take advantage of them. In some cases, we've seen where families come and take away the children and see this person who has given birth and she's useless, the children are taken away. We've seen in some families where women who abuse drugs kicked out of their houses, and they experience trauma differently from what we even see with the men. The society is less tolerant to women who abuse or inject, for example, drugs than men. And one of the other areas that is so challenging for the same women is that because, again, they may not be able to get income to sustain the behavior, they tend again to also, as I said earlier, move to something again dangerous like sex work, which then they begin to get money to sustain the drug use. So because of that, the criminalization of drug use, the criminalization of sex work, and again, the fact that these women are subjected to emotional violence and exposed to a lot of also gender violence, including physical violence, not only by the people they live with in the community, but also even passerbys. So they become one of the most vulnerable groups in the society. Actually, if you had to have a hierarchy of needs, this group of women really have the highest needs. Secondly, in some instances where even when some of them are pregnant and they are active users, they don't get the care that they need. Because a lot of times is that, as I said, they are just neglected. So this is a group that we are saying that we need to acknowledge that there is a special needs for this particular group. Sanitary towels, we have seen cases of women who inject drugs who cannot even access sanitary towels. And they live in really bad conditions. So we need to look at the women as we look at the entire cohort of people who inject drugs, but also have a lens of women and the needs that that they need to be taken care of.
Okay. I have to take a quick break here on the Monday report. When we come back, we're still talking about persons who are using drugs and injecting them in HIV transmission. We're trying to find out, is there a silver bullet to resolving this issue? That is our main conversation here. There's the policy aspect and then there's a human aspect as well. How do you integrate them back into the family? We'd like to hear from you at Trevor Mbija at Citizen TV Kenya. # Monday Report, 22422 is your SMS line number. We'll see you in just a bit.